I'm really pleased that we get the opportunity now to hear from our keynote presenter, Dr. Marion Forgatch. We'll move right along. Dr. Forgatch is going to talk about 50 years of arguably one of the core or the core parent training programs, parent management training, the Oregon model. And I'm so pleased to welcome her today. Dr. Forgatch is a pioneer in developing evidence-based practices to help parents. She is a key developer of Generation PMTO, Parent Management Training, the Oregon Model, a landmark evidence-based prevention intervention that has been implemented around the world. Dr. Forgatch and her life partner, Minnesota Ely native, Dr. Gerald Patterson, developed PMTO based on the analysis of thousands of hours of video footage documenting parent-child interactions to help understand what leads children astray. PMTO is based on 50 years of research and has been shared with more than 50,000 families from all socioeconomic backgrounds, cultures, and family types across the world. PMTO has been adapted by other researchers to serve more specific audiences, including Latinx immigrants, parents of traumatized children, military parents, immigrant and refugee parents, and others. Dr. Forgatch is Senior Scientist Emerita at Oregon Social Learning Center in Eugene, Oregon, and the founder of Implementation Sciences International, which distributes PMTO across the world. And on a more personal note, Dr. Forgatch has been a personal mentor for me for the last more than 15 years. So it's really a special pleasure to welcome her here to Minnesota, and she can share with you what the amazing work she's done.
Yeah, no, I'm fine. Good morning. What a pleasure to be here in this beautiful place, and am I glad I wore purple. Well, I'm happy. Let me see. I just want to make sure I know how to move things around here. I just want to. Where are you? I just need to move the right. How do I always have this problem. We went through this before I started. No, I just want to click onto the next thing. Bravo. So Jerry Patterson got his PhD from the University of Minnesota, but more importantly, he grew up in 13 miles outside of Ely, Minnesota on Robinson Lake. And I have been here for two reasons. One is to give this important talk to you folks today, and also to bring his ashes back to Robinson Lake, his last request. So this is a very special occasion. But Patterson, and by the way, people would say to us, do you ever get beyond calling each other Patterson and Forgatch? After 45 years, you know, it helped to be formal with each other. He had been trained psychoanalytically, and he worked in the Wilder Clinic, and they worked with kids who were severely troubled. And when the kids would come home, they'd bounce right back. And he felt that this was not the way to work, that parents were really important. And so what he did was to go directly into the homes of families to see what was taking place. And that's where he came to the revolutionary idea that parents matter. I know for years, and they still do it, they treat the child, they leave the parents in the waiting room, they don't know what happened, and then when the kid goes home with the family, the parents don't quite know what to do. So he developed the idea, he along with some other people like Sid Bijou and Bob Waller, that parenting, we need to work with parents. The therapists need to give the skills of how to deal with kids' behavior to the parents directly and help them learn. So I'm going to take you on this 50-year journey from developing the idea, the theory that, for example, if you look at this, okay, now, our focus is on the child or adolescent, but this is the most proximal context, the parents. And on this side, what you have is positive parenting, and on this side, you have coercive parenting. And what happens in stress, in this outer rim here, is adverse contexts. And when you get, I'm going to move on to the next. How do I move onward? Pardon? Pardon? Oh, thank you, the arrows. Every system is different. It's not like I haven't done this before. Okay, so this is another way of looking at the same theoretical perspective, that adverse contexts disrupt parenting, and they make you more irritable, more angry. You say things you wish you hadn't said, and when somebody says something back to you, you respond in kind, and what you get is an escalation until somebody really lays out the whammer, and they win. And what happens is they win the interaction, which may be nice in the short run, but in the long run, what they learn is the way to get along is to fight your way up until you get the biggest and hardest blow. So what we do is we focus on positive parenting to replace coercive parenting, and that's what has the effect on child outcomes. And let me count the ways of stressful circumstances that come into the lives of families. These are about 15 or so, but I'm sure that you can all see that I've left out some more that are very important as well. So now what I'd like to do is show you an example of a coercive interaction that takes place in the great battleground that we see every day, the grocery store. Now, I'm clicking, but nothing's happening. I'm glad Trevor's right there. I told him, be near me. I need my hand held. I mean, you don't have any sound. Technology. You know, it's hard to know whether you want to love it or hate it, and it's when you most need it that it lets you down. But then you have someone like Trevor here who can
sort of let you down.
No sound. Ah, there we go. No?
There's sound.
Now, don't you wish you didn't have sound? Have you ever seen anything like that? Has your child ever done a tantrum? Maybe not at that level, but have any of you parents ever lived through the embarrassment, the humiliation of a tantrum at home, but in a public setting like that? Well, this is coercion. And guess what? He gets those bonbons in the end. And he gets them because it's the only way Pop can see to shut him up, and stop the humiliation. And that's the problem with coercive interactions. So in our model, we focus on these positive parenting skills to replace coercive processes that take place in the family. But one of the things that Patterson particularly was focused on is it's not just the information, it's not just the content, but to get families to change is a very, very difficult process. And so you need to have highly sophisticated clinical skills. And behavioral approaches often have the reputation of being knee-jerk reflex and not forming close relationships with families and understanding their storyline and bringing them along in the change. And so we focus very heavily on the process skills and also how we teach parents these effective parenting practices. But as you know, as clinicians, it's really hard to do it if you're in a workplace that doesn't give you a lot of support for the hard work that you're doing and the stressful work that you're doing. And you also need not just evidence-based practices, programs that work. You need coaching along the way because you want to sometimes give up, especially when it doesn't work. And when it doesn't work, it doesn't mean that the program won't work. It's just that you need to continue to figure it out. So we have worked with efficacy trials through a wide range of different samples there in that blue box that we saw in highly stressful circumstances. And we've done it from prevention through treatment with seriously difficult kids. So on the top there we've got divorcing mothers. So one of the stressful times in family is divorce. And recently separated single mothers have a very hard time. They tend to drop in their SES level, and they have to go through all kinds of transitions. And they have transitions and difficulties, but so do their kids. And so our goal is to empower the parents to live through these stressful situations and provide strong support for their children as they're making those transitions too. So we've got divorced mothers, step families, schools in high crime neighborhoods, and that's just a preventive, universal prevention sample in which everybody got the intervention. Kids who've been removed because of maltreatment. Kids who've been adjudicated because of delinquency. And when we did our delinquency, multiply offending delinquent adolescents, we found that to be a really difficult sample to work with. And Patty Chamberlain then said, there's got to be another way to do it. And she developed treatment foster care, and she's done it for kids who are delinquent, boys and girls separately, because as you know, girls and boys and their issues are different. And then kids who were in the state hospital, in the back wards of the state hospital, bringing them into foster care. So in all of those samples, what we showed, okay, now I'm going to put on that laser, I think. Trevor, help. Where is it? Yeah. Okay. Okay. Thank you. So what you do is you have a random assignment to the sheep dip, PMTO, or treatment as usual, no treatment. It depends on prevention samples. Sometimes you can do a no treatment sample, but it's always best to have an alternative treatment to compare it to. And the goal is to show that you can change child outcomes. And here the kind of child outcomes that we've changed are arrest rates, severity of crime, substance use, noncompliance, delinquent behaviors, improved academic functioning, reduced out-of-home placement, reduced deviant peer association and reduced internalizing behaviors, especially depression. One of the things that's been surprising to us is that outcomes that we're getting that we hadn't anticipated. We did anticipate reduced maternal depression, but we have an increase in standard of living and a rise out of poverty for the recently separated single mothers, reduced arrest rates, and improved marital adjustment and satisfaction. So I'm going to show you an example of one of those studies of recently separated single mothers. There were 238 single mothers with boys in grades 1 through 3, and we chose boys because, now this was done in the early 90s, not in the 80s, but in the 90s, and we knew that boys were at risk for showing the greatest increase in behavior problems, so we wanted to show we could slow that down or stop it. And we have 9-year follow-up on that. So the intervention was a manualized program. It was parent groups, 14 sessions, and we followed up with midweek calls. So we would have a parent group, and then each parent would get a brief call during the week to provide support, answer questions, maybe prompt them to do their home practice assignment, which was always difficult. And the sessions included things like, the opening session is like, all right, you're going through change, but change can be your friend. So let's make change your friend by taking charge of what's going on in your life and helping your children through this process. And then we work on encouragement, teaching through encouragement. And I think that's one of the main things that we do is, in this society, and maybe many societies, teaching through correction is easy. People get it fast. And it's a tendency that we have. No, don't do it that way. Do it this way. And what we try and do is to teach parents to set kids up for success and then encourage them for each step that they take along the path of growing and improving. Setting limits is always a problem, but kids are out of control sometimes, like you saw in the grocery store, and you need strategies to deal with that. Now, the time to set limits on a kid like that is not there. You have to do that in other situations. You need to pre-correct for that. But setting limits, and setting limits for kids from like 2 through 16, 17, 18. And that requires a range of different strategies. So let me show you some data. These are police arrests in that sample for these boys over the course of 9 years. And what you see is the kids in the no intervention control group are blue. And that's growth in police arrests over the course of 9 years. And the kids who got the intervention are in red. And you can see there are a lot of kids who didn't get arrests. There are a few red lines in there, but the vast majority of the kids whose mothers, and we didn't work with the kids, because at that time there was this thing going around saying that parents don't matter. And it's not that I believe that you shouldn't work with the family or with the kids, but I wanted to do a study in which I could show that if you just work with the parent and not the kids, you can change the trajectory of the children. So in this case, these kids, we didn't treat them, we treated their mothers, and these are the outcomes for police arrests. Now that's the mean for the two groups. The blue is the control group, and that's growth. This is the mean for the mothers for police arrests. We did not anticipate that mothers would also show a reduction in police arrests as a result of having a parent training program. It was really pretty surprising. So these are some other effects that I want to tell you about. If you look at this black line in the center there, that means there was no effect. The intervention, there's no difference between the intervention group and the control. This is the first 3 years, and then I had a hiatus in funding. that happens. And you don't collect data when you don't have funding. But I got refunded. And so I got the sample back, and we had about 85%. We sustained data collection with 85% of the sample over 9 years. So, but this is the largest effect size we had. And this is per capita annual income. Now, one of the things that they say about single mothers is the only way that you can increase their income is for them to repartner. This controls for whether, or this graph does not show that control, but we did control. And yes, mothers partnered, unpartnered, partnered, unpartnered, but for the vast majority, they had this incredible increase in income. Sorry. This is another point of interest. So here is parenting, and we show the biggest effect shortly after the intervention in parenting, and it sustains at 3 years, and I don't have the data for parenting out here. This is teacher reports of delinquency, and this I think is something important to look at in prevention studies, especially if you're intervening not with the child, but with the parent. It takes a while for the effect to take place, and at 1 year we had no effect on teacher ratings of externalizing behavior. Here's 2 years, here's 3 years, and here's holding it out to 9 years. So while we had no effect on that at 1 year, we had an effect that grew and sustained over a long period of time. This is internalizing by Boy Report. And so these are multiple agent reports. So some of it is observation, some of it is police arrest, some of it is teacher report, some of it's parent report. So now I need your help again. So what do parents say when they get an intervention like this? These are, one is a grandmother who is raising her grandchildren, and one is a mother of 6 kids. All of the kids were in the community mental health, and this is in Detroit, and they were diagnosed as severely emotionally disturbed. So these mothers are, these caregivers are telling oh, I did it wrong. Thank you. He warned me I was going to have trouble. Now we need sound.
A program that could kind of help you get on track to being not just a loving, caring parent.
That's the easy part.
That's so easy, and I know that sounds really crazy, but it is. It's really easy to love your child. It's a whole different avenue when you have multiple issues that you don't even know how to cope with, or
well, that's what kinds of the main pieces of PMTO did you start using first?
Oh, one of my favorites that I still use, and just yesterday, my grandson said, I took my medicine without you telling me I should get a Scooby. The Scoobies are awesome, and I still use them. That was the earliest thing. Rewarding, letting your children know that you recognize that they're doing something good. They're not bad all the time. But if you don't focus on it and retrain your mind to recognize and reward and let them know, you see that they're doing good things, being nice to their siblings, doing a chore without you telling them, finishing their homework without complaining, picking up a jacket off the floor and hanging it up. Oh my God, he picked up a jacket. Scooby, he's learning these
through
things.
your encouragement.
And the more I recognize, the more he does these kinds of things. So I can say more than I say stop, don't do that, come back, leave that alone, stop making that noise. Now I can say, that's wonderful. How thoughtful. That's great. I love that you did that. I get to say these kind of things. I hadn't said things like that in years.
Okay, I guess that one is over. Okay, so you get a program, you try it out in multiple ways with multiple samples from prevention through treatment with severely emotionally disturbed kids or delinquents or all sorts of different samples, and it works. Very nice. It's all done in an ivory tower or an academic setting where you have total control over what's going on. Can you take it out into the community? And that is the issue that Abby mentioned. It takes 20 years. Well, it took us more than 20 years to get into the community. It took the Norwegians coming to us and saying, we want your program. It works. And not only do we want it nationwide. And well, we didn't know how to do that. So that was in actually, they contacted us in 97. In 99, we started, and that's pretty traditional. It takes about 2 years from first contact until you get started. And then it takes about 2 years for things to go on. And so what has happened in Norway, we trained 30 professionals, and they brought these 30 professionals from all over the nation. And they since have trained 1,300 professionals, and more than 20,000 families are being treated by this. And we all started in 20 years ago, not quite 20 years ago, with 30. And so the approach that we use is full transfer. That is, we train a small number of professionals, and we ask the organizations to select people that they see as having the potential for leading, because they are going to be the ones that carry the program forward to future generations, to train, to coach, to do fidelity ratings, and to keep the program going. So since then, we have done these large-scale, full transfer implementations in Iceland, Michigan statewide, and in Michigan, 76% of community mental health agencies who treat severely emotionally disturbed kids have fully certified PMTO clinicians working there. And we started there in 2004, 2006, and they are still going strong. That's another thing about implementation. It's very hard to get a program to train professionals and keep them going. 8 years after we trained the initial generation one clinicians in Norway, 92% were still certified and providing PMTO services. The Netherlands, Detroit, so I know Detroit is in Michigan, but it's just about half the size of Michigan and a different kind of population. So we did a separate implementation in Detroit, and then they integrated it, the Michiganders integrated it within the state. In Kansas, with severely emotionally disturbed kids who had been removed from their birth parents' home and were in foster care, that's a recent one that we just finished. In New York City, in working with birth parents of kids who had been removed, and currently in British Columbia, where we're doing telehealth delivery. So we train professionals, and our training programs are really quite a lot of fun. But we started out when we first were training in Is it really only 9:15? Yes? Okay. Time flies when you're having fun and technology problems. We have a lot of fun as we're training clinicians. Now, our first training, where we didn't really know much about what we were doing, we wanted to be sure we did a good enough job. The training program was 18 days, and it took 2 years to achieve certification. Nevertheless, when you do full transfer, you want your folks who are the core, the ones that we train, to really understand it, to have it, as they say, under their skin. So it takes longer to train this first generation, but then they carry it forward, and you're no longer paying us, except for maybe our checking Fidelity on an annual basis. You're paying your own staff. So you're investing in your own staff when you do it this way. Oh, okay. This is, so one of the transitions, we've gone through many, many adaptations, and when we work now with birth parents whose kids have been removed, using the social workers in the child welfare system, we often have to help the clinicians take a new perspective on the birth parents, because not all, but many feel that the birth parents are perpetrators and they have done harm to their children, which they have, but many of them really want to know what to do and they want their children back. So one of the first things that we work on is identifying these parents' strengths, which helps both the clinicians working with them and the parents. It empowers them. It helps them remember that we too, have strengths. And sometimes when we ask parents to identify their self-strengths, it's a tearful situation because they can't think of it. They can think of strengths in their kids, but not, I'm gonna show a video. Trevor. Okay, and now I can't make anything move. There, this is a group in Michigan who had who had the parent group for Reunification, and here they are getting certified that they completed the session, and they're so excited about it. And now I'm going to show you a video of a group of parents whose kids have been removed talking about their feelings about the group and how it is to get their kids back. A little difficult to understand, and one of the moms says, "I got my baby back."
Yeah, my baby was looking forward to.
Yeah, Maya, he's just so funny. Her son, he enjoyed everybody. He be looking to where this person.
Like this, the first thing I ever completed in my life.
Wow.
Like something.
Well, congratulations.
Besides get my baby back, and then like something like this, because I never went through a parenting class or nothing like this, and I'm proud of myself because I completed something.
You should be.
And you got the house. You got the house quick.
Well, some of the things that we covered, I learned.
Good.
I didn't necessarily. It might have been some things that I might have been doing, might have been similar to what they had taught me, but I didn't know how to apply it until they gave it to me the way they did the format, and it came out a whole lot easier. Yeah, I switched. Yeah.
So parents feel empowered by these groups. Not all of them make it through. And after they complete this series of 10 sessions, while their kids are in care, when the kids come home, we have 6 more sessions, because what you learn when your kids are in care is different. When they come home, you need to be able to put it into practice. You make all the mistakes that we all make as parents, and they make them too, and they need support and guidance for how to make it through that. So I have been blessed, really and truly, with a group of mentees, colleagues, who have adapted the program in all sorts of different ways. And I know the print is really small on here, but I have a group of Latinos who have taken it for Spanish-speaking families, recent immigrants to Mexico. They not only have adapted, translated the materials into Spanish, but they've made the pictures, the parenting materials, look right for their population. The metaphors fit within the families that they're working with. And then Ruben Paracaradona, who was at Michigan State University, and now he's at Texas, but he wasn't in Houston, thank goodness, recently. He has done a program for Latino teen dads to engage them in the process of fathering, even though they may have kids that they don't live with and have little contact with. And also he's done a trial in which he had a waitlist control. He had parents who got an adaptation that was culturally correct, but also then he added another group that got 2 extra sessions that had link workers that helped connect them with home, school, and immigration and deal with those kinds of issues. And he asked, which do you like better? And he looked to see whether their parenting changed and the kids changed. Parenting and child behaviors were positively influenced by both groups, but the parents, of course, preferred the one with the 2 additional sections that help the parents deal with the difficulties of living in a different culture. One of these that I want to mention, well, Abby, of course, has taken our program and done it in shelters for mothers who were living there because of homelessness or domestic violence, and showed that it worked, and that parents completed the course. One mother was apparently thrown out of the shelter because I guess she was stealing, but she came back for the parenting group each week. It was that important to her. Abby, of course, and she's going to talk about what she's done with the military families. And then Liz Wheeling, who is here in Minnesota, has taken the program to war-displaced mothers in northern Uganda and working with Karen refugees here in Minnesota. And Chris Mayhus, I know you're in here somewhere. There you are. He's been involved in this work both in northern Uganda and with the Karen refugee population. So we've been around the world, and we've got the program adapted for different populations, and the modifications are done with positive outcomes, and Abby will tell you about the outcomes she has for ADAPT. Now, in northern Uganda, it was really kind of interesting how they conducted these parent groups. They were Akoli mothers, and they did 2 parenting groups with sessions of 3 hours twice a week. And the incentives that they gave them were really interesting. 1 kilo of pasho and beans. Because you see, if the mothers had not been coming to the group, they would have been getting food for the family. So the incentive that worked for them, and this is one of the things that you need to do as you adapt your program for different cultures and contexts, is to make sure that you make it worthwhile for the things that are of value to the people that you're working with. And the materials, many of the mothers had never had any education whatsoever, so the materials were adapted so that there were not words. You did not need to read to be able to be using the parenting materials. I think that was especially creative and important for this population. So, okay, here's another picture of how we've been through the world, and I want to talk just a tiny bit about using this full transfer approach that I mentioned that we did in Norway and that we do in all of these other places. What you need to do is we pass control of the program into the hands of the community, so we need to make sure that there is an infrastructure that will carry the program forward. Because the thing that will most likely fall apart is Fidelity. And one of the ways that we manage Fidelity is we videotape therapy sessions. And then we look at the therapy sessions, and we look at them during the course of coaching and supervision. And it's not just what you say, but when you look at it and you see what's taking place, it's an opportunity to get more perspective on what's happening. I was raised with video supervision. I never, ever worked without videotape supervision. It's a bit painful, and one of the, especially if you are lucky enough to work in a group that is supportive enough that they don't nail you for what you did wrong, but that you can show what you did wrong, and they can help you get your foot out of your mouth and move forward with the family, because we all make mistakes. Anybody who's honest will know that in your sessions, in fact, probably almost every session you ever do, you make mistakes. And the thing is to learn to get your foot out of your mouth gracefully and continue dancing on down the road. Why is this not moving forward? What did I do? Help! So we have a coding system to rate the fidelity of therapists, and it's based on observations. Thank you. Oh.
Don't say thanks yet.
No. It's all very simple, really. You just have to have a wonderful guy like Trevor standing beside you. And in fact, that's one of the things that's necessary about doing good treatment, is you need support, somebody standing beside you when things don't go the way they should. So we have this fidelity rating system that is based on observations of actual therapy sessions. And we have 5 main dimensions to it. Knowledge, and that's just content. So content, that's that diamond in the center of that flower I showed you. Content is important, but are you able to structure the session so you can get through it? Do you teach in such a way that the parents are learning? And do you have that quality process skills that shows the parents that you're traveling down this road with them? And overall, one of the main questions we ask is this family likely to come back? Are they likely to try it out? Do you think they learned anything? And what's the relationship between the client and therapist? So I'm going to skip through this, but we maintain a regular meeting every month, and we look at videotapes from our implementation systems around the world, and we come to consensus scoring it. And so here we have someone in the upper left-hand corner. She's from Iceland. The woman in the middle on the top is the leader. She's Icelandic of our fidelity rating code. That's me over there in the top right. Melanie Dominique Rodriguez, who is Puerto Rican and at Utah State, and one of the persons who's created adaptations for Spanish-speaking families. Laura Rains, who's our Director of Implementation and Training, and you know that woman, Abby Gewertz there. So what good is a fidelity measure if it doesn't predict change in parenting and change in child outcome? So we conducted a study, and you don't need to worry about it. It's a structural equation model, and what it says is, if you look at intervention fidelity and you score it and you make a construct of measures of that, will it predict change in parenting? And this is change in parenting from before and after therapy, and it's based on observations of the parent-child interaction. And the top box there is change in mothers, and the bottom is in fathers, and it's saying, yes, it shows change in parenting. And we did it with 2 samples. One is an efficacy trial that we did in Oregon, And the N was 4 therapists and 20 families, and you say, yeah, well, that's not very much. But in Norway, the N is 114 therapists and 238 families. This is a different language. This is a different culture. The measure of fidelity is taken during treatment, and we're looking at change before and after treatment based on different systems of observation. So we've got a good measure of fidelity. I'm going to skip that. So if you're doing full transfer, won't fidelity get worse with each generation of therapists, especially when the developer or purveyor of the program isn't doing the training anymore? Patterson said, Forgatch, you know, it's just not going to hold. So I said, okay, well, we'll test it then. He always made me test things. And so this is looking at Iceland, Netherlands, Denmark, and Norway. And the thing that we found, which is really interesting, in all of those places, yes, indeed, there was a drop from generation 1 to generation 2. But from generation 3 and forward, they recovered whatever level they had that was trained by us. They recovered it. So all of them experienced a drop, but it was temporary. And I think, I only have hypotheses. It's not yet tested. I leave that to the younger generations to do that. Maybe you folks will do it. What I think is that everything has to be translated into the new language, the new culture, the new trainers need to get, you know, some experience under them and keep going. Okay, here we go again. I can just click here. Oh, good. Easier said than done. Okay, here it is. This is a group of parents at a state conference in Michigan.
The biggest thing that I carried is the good directions, because how you speak to your child is, you know, basically how they're going to respond. And I mean, I wrote down a bunch of other tools too, but like I reteach good directions to people everywhere we go. Like the OT knows good directions now. You know, the teachers know good directions. It's in his behavior, BIP, the BIP. You know, so those things are like, yeah. So it's like good directions will make all the difference. Really.
The biggest tool for me was emotional regulation. Since I've learned to ask more questions and probe and pry, they talk to me more. When they get in the car after school, I have a middle schooler and an elementary child. So as soon as they get in the car, I say, what was your favorite part of the day? In the event I forget, they'll say, Mom, you didn't ask me what my favorite part of the day was. So for me to be emotionally regulated, for me to touch them, keeps me calm. And as long as I'm calm, they're calm. Then they go, well, what did you do today? What was your favorite part of the day? Where did you go? So it turns around, and I earn and where we've evolved to. I got my child back, but I also found myself as a single parent.
My biggest takeaway is that this is really like a lifelong intervention. He's 5 now, but when he's 13, I can still use the same things that I've learned. And even know that PMTO is here to stay, and I can get refreshers when I need them. And so knowing that that opportunity is available and that I've invested a little bit of time now, you know, for the long run is really, that's the biggest takeaway for me.
So this was, one of the things that they do in Michigan that is so outstanding is they have a state conference every year, and they bring together all the various clinicians, PMTO clinicians from around the state. And they always have a parenting panel, and this is what this is, of parents who have been through the program telling what their experience is. And almost always, the parents and the audience are in tears, you know, as they tell their stories about how their kids, it used to be they sat in the waiting room. Now in Michigan, it was not easy because the state system was set up that unless you were working directly with the child, you could not get paid. And so the director had to get the state to change the law that you could work with the parents. And if you're working with the parents, then they also had to set up the agencies so that they had childcare available while the parents were in the room, because it used to be the parent sat in the waiting room while the kid was in the treatment room, and then the parents went home and didn't know what to do and how to change things. So I have lots of references here, just in case you think this is all based on. And you're welcome to the PowerPoint if they can get it to you without the parent, without the parent, the videos in there. But you're welcome to the material, and I'm very happy to answer questions, send you papers, follow up with me. Oh, and I'm supposed to tell you that Jerry and I wrote a book recently on parenting, and we put some flyers out there at the front desk that just came out, Raising Cooperative Children. I'm not very good at selling this book, but it has the program and how to do it, and it's written in a way that's user-friendly for parents. So, and it's available on Amazon.com. I don't know how to sell it other than that. So I'm delighted to be here, and I'm available to answer questions. Do you have questions?
We have time for Q&A, so we have some mics around the room. So any questions?
Somebody's pointing back there. Spanking. Yes. So the question was, have we encountered spanking, and how have we addressed that? Now, that is an issue of culture, discipline. So, for example, in New York City, they laugh at the idea of timeout. You call that punishment? What good is that? In British Columbia, when we teach parents to give a clear direction, we say, Johnny, pick up your shoes now, please. They find that now, saying now, is too aversive and too directive. It's kind of mean. So cultures range in what they think about the harshness of setting negative consequences on kids to stop problem behavior that causes people to turn away, that causes kids to escalate into behaviors like you saw at the beginning of that little boy in the grocery store. By the way, I remember throwing a temper tantrum as a child, and it is one of my most humiliating experiences in life. It's bad for the child to be allowed to go that far out of control, and it behooves parents to stop them early in the process. So, some parents feel that punishment should sting. It should hurt. They should carry it with them. And other parents feel that timeout is far too harsh. So I used timeout with my son the first time, a gazillion, he's now 51, so it was a while ago. 47 minutes. And he threw a tantrum for 47, and we didn't know how to use timeout in such a way that it was very effective. We never go beyond 10 minutes now. And at 10 minutes, we give the kid a choice. You go to timeout now for 10 minutes, or we take away a privilege. And depending on the age of the child, the privilege is from 15 to 30 minutes long. So you got 10 minutes, 15 minutes, or 30 minutes, which a child learns that they're going to take the 10-minute timeout. By the way, we start with 5 minutes, and we add 1 minute up to 10. And at 10 minutes, they get the choice, 10 minutes timeout now, or you lose 30 minutes screen time, or you make a list of privileges to remove. So, okay, Parents want to spank. Parents want to ground their kid for 3 weeks. By the way, we also use work chores. That is, and they range from 5-minute work chores to 30-minute work chores to, for example, if a child has stolen something, we might give let's say they stole something that cost $50. You might say, okay, I'm going to pay you at $10 an hour rate. You got a 5-hour work chore, and you would give it to them at 1 hour a day for 5 days, and you would withhold privilege until that 1 hour of work was done. So we understand parents who spank, and we usually can empathize with them and say, it probably hurts you to spank your child, and you probably rather do something else. You want to set a consequence that stops that nasty behavior, right? And they'll agree with you on that, and they'll agree with you that it hurts them to spank their child. Most of them, not all. I know, So we have some alternative negative consequences that you can use, and they work. They're hard to be consistent with, and maybe you can't do it. I have to say, we do a little bit of paradoxing along the way. But then we set them up to do it. But we first teach them to teach through encouragement. We don't add discipline until about 7 sessions in. And that's usually where we get the most resistance in working with families. Other questions?
Any other questions?
Is that it? All right.
Thank you so much, Marion.
It's been such a pleasure.